Welcome. Welcome,
Thank you.
everyone. We would like to invite you to put your name and your organization in the chat, just so we have a sense of the different health centers that are able to join us today. And we will get going in just 1 second. So while you're putting your name and location in the chat, I'd like to let you know a couple housekeeping items about today's webinar. This one is going to be a little less formal than some of our others. There's not going to be a slideshow, so there really will be a lot of great opportunity for discussion, to ask Dr. Elzinga questions as we go. And so please, as he's talking, type your questions in the chat. There'll also be opportunities to come off mute during the webinar as well, to really have that interaction. So without further ado, I'll turn it over to Dr. Hans Elzinga, who is a family medicine doctor at Salud Family Health Centers in the northern part of Colorado. And he currently does many endoscopic screenings at Longmont United Hospital. So without further ado, I'll turn it over to Dr. Elzinga.
All right. Thanks so much. We're going to try and figure out our audio here because I'm hearing myself on another computer. So this is my first time using this kind of a system for a talk. So just let me know if things are not working correctly. Also, if you're having problems as far as sending me a question and I'm not answering it, just let me know because I may not be able to see them on my computer. But so what I was asked to talk about today is about sedation for colonoscopy, and then also about the possibilities of unsedated colonoscopies. So we have been here at Salud a partner with CCSP since its inception, and I've been doing colonoscopies now for over 20 years, so I've seen a lot of changes in how sedation is done. And I know that you all are navigators, but I don't know how many of you have seen colonoscopies actually been performed, been in an endoscopy suite, or perhaps even had your own colonoscopy, which depending on the type of sedation, you may not actually remember anything about. So I'll start with some of the basics as far as the types of sedation. So colonoscopy has been around for many years. Flexible endoscopy has been around since the 80s. And some of you may remember, if you've been around in this for a while, about flexible sigmoidoscopies, which were fairly popular in the 1990s. And one of the reasons that they were being advocated is that they could be done without sedation. And they were only to be done every 5 years, could be done in the doctor's office, and had an easier prep too, as far as a lot of times they were done just using some enemas before the procedure rather than a full prep that you all have likely been counseling your patients about how to do, and one of the least favorite parts of the procedure for most people. However, one of the issues with flexible sigmoidoscopy and why it didn't take off so much, even though it was much cheaper alternative to colonoscopy, is because they were done without sedation. And part of the reasoning behind that was that if you did a procedure that only went up basically as far as the splenic flexure, so just the left side of the colon, that this was more comfortable for patients and they could tolerate this more easily, and therefore not need sedation. But I think in actuality, in the real world, this was felt to be a very uncomfortable procedure, and people's expectations that it was going to be a easy procedure to get done were not oftentimes realized. And so a lot of people had one of these done and never wanted to have one again. And so now in the United States, it's not very commonly done as a screening procedure. Elsewhere in the world, sometimes it is for those very same reasons. So one of the reasons why colonoscopy has been more popular is not only that it is a more thorough diagnostic examines the entire colon, so it actually does a better job of preventing colon cancer, but it's done with sedation in most locations. So for that reason, it's better tolerated by most patients. So the most common historically type of sedation that was done using Versed and fentanyl now, but prior to this was oftentimes Valium and Demerol. So anybody who's been around this a while may remember when that was the most commonly used medicines. The problems with Valium and Demerol, there were some additional side effects. Medications lasted longer, so they took longer to go away for the patient as well. So they were much more sedated for a longer period of time. So Versed and fentanyl became the most commonly used medicines. And Versed is a very short-acting benzodiazepine. It's also called midazolam, is the generic name for it. So as a benzodiazepine, it's related to Valium, so it helps for anxiety. And then it also has an amnestic response. So one of the things that happens is that they will actually have a loss of memory, oftentimes for the procedure. This is not a guarantee. I think I was looking for questions. I haven't seen any questions, so if you sent me one, just let me know. It is an amnestic response that is not 100% consistent patient to patient. So with high doses, sometimes people still remember things. Even with low doses, sometimes people remember nothing. So that amnestic response is not entirely predictable. It also is part of the reason that we tell people that they can't drive after the procedure. The amount of time that people are not supposed to drive for midazolam varies quite a bit, place to place. We had for a while at our institution that they were saying only 5 hours and people could actually drive, but I think the most common is 12, and some places still use 24. The other medicine that's used with midazolam is fentanyl. And fentanyl now has been in the news a lot more because of the opiate epidemic and deaths related to this. And fentanyl, because of it being so extremely potent, is one that has had many deaths related to it, not in the sedation realm, but more in the illicit drug realm, or using them improperly. So there are fentanyl patches, lozenges, a number of other different ways that it can be used for outpatient, but we're using it through an IV. So it's extremely short acting that way, and it's basically an opiate, synthetic opiate pain medication. So what it does is decrease the discomfort. And then the two, Versed and fentanyl, are synergistic, so meaning that the response to both is greater than what it would be expected just adding the two together. So they actually multiply the response. And in some ways that can be good in that you have to use less of the medicine, but it can be bad as far as certain side effects. So it will affect blood pressure. It can cause respiratory depression. So whenever people are receiving these medicines, they need to be monitored throughout the procedure and for afterwards. There are medications to reverse these agents. So you can reverse fentanyl with Narcan, just like you would do for an opiate overdose. You may have heard about those being used, Narcan being used, for example, on college campuses or other places to help so that they can reverse somebody who has an unintentional overdose. And then the medicine for reversing midazolam or Versed is romazicon. The thing that's important about both of these medicines, the reversal agents, is that they don't last quite as long as the medicines that they're reversing. So if they're used, then the patient needs to be monitored for quite a while afterwards. So in general, we try not to give people doses where they need to have a reversal agent used. Most of the time, that's not an issue as long as you use the medicines judiciously and people do well with them. Like I said, the amnestic response is variable. One of the issues that comes from that is you can talk to a patient after the procedure. They can ask you what seem to be really good questions about the procedure, and they won't remember even having talked to you. So a lot of times it's necessary to wait until later on in order to give patients results, because they're not going to remember things even if they seem like they've completely recovered from the sedation. This can be important as well, as far as people thinking that they're okay to drive, but they really aren't. So there are some issues around it. The nice thing about Versed and fentanyl is that they can be done by the endoscopist. So as we'll talk about in a little bit, that can actually decrease the cost of the procedure. So what I do is generally use Versed and fentanyl for almost all of my procedures. The important thing to know about this too is that if people are saying things like, I don't want to feel anything from this, I think it's important for expectations for them to know that this is conscious sedation. It's not general anesthesia. So there are some benefits to that. One, they're not intubated. They're not on a ventilator. They can tell us if they're hurting, so they don't have to worry that they're going to have a problem where they might be, for example, paralyzed and not able to tell the provider that they're having pain. So they don't have to worry about those things. But they may, like I said, because of the variable response to the amnestic response of Versed, they may remember some of it, and that's okay. And I tell them that's to be expected. And that can be a helpful thing as far as patient expectations that, yes, they may feel something, but if they're hurting, we can give them more medicine. We'll make sure that they're comfortable, but they may remember some of the procedure. And I've had many people tell me, and it's a small percentage overall, but they'll remember waking up during the procedure. They don't remember quite why, and then they remember going back to sleep. I think a lot of times that's when they're having some discomfort. We give them more medicine, and then they go back to usually sleep. But some people, um, due to other medicines or due to perhaps some natural or genetic differences in how they metabolize the medicines, will not be very sensitive to Versed and fentanyl. And so those people can sometimes be very difficult to sedate, may have only a limited response to the medicines. Sometimes we can get around those by doing some alternative medicines. Ones that I've used is Benadryl, can be helpful for that given IV. So the antihistamine can sometimes help with that. But because of some of those issues around it, including the fact that some people have, especially at higher doses, significant nausea and vomiting after the procedure, it's now become much more common in a lot of locations to use propofol for the sedation. And it's actually considered to be not conscious sedation, but MAC, or modified anesthesia care. At almost all institutions, and I think just about everyone here in Colorado, propofol needs to be done by an anesthesiologist or nurse anesthetist. There are some locations, rural locations, I know like in Alaska, where sometimes they'll have an RN who's doing that under the guidance of a physician. But I think almost everywhere it requires either an anesthesiologist or a nurse anesthetist. Propofol used to be called more commonly Diprivan. A lot of patients know it as the Michael Jackson medicine. So if you recall, and it's been about 10 years ago, Michael Jackson died from propofol. And he also had, interestingly enough, I believe, midazolam and something else, but on board. This was being administered by his private doctor, who is actually a cardiologist, not an anesthesiologist. Sounds like he was not monitored, but sometimes that does cause some fear for patient when they realize that. But it's actually, there's a reason that it needs to be monitored more carefully even than the Versed and fentanyl, and that's because it can cause more profound respiratory depression and airway difficulties. It also can cause blood pressure to drop as well. The medicine I remember in residence, we called that medicine milk of amnesia, because it also has an amnestic response, and it looks like milk. It's a white liquid. It causes sometimes some significant pain when it's injected, and so patients need to know that that's a possibility. Most of the time they don't remember that, but certain people I've seen have a severe pain just with the initial dosing of the medicine. A lot of times it's given as a drip. Other times it's given in small boluses, but it has a very short effect. It actually will go away within 10 minutes. There's not any reversal agents for it, so you basically have to just wait out the effect, although it is short. it has a number of advantages over Versed and fentanyl. And one of the ways that I've used it much more commonly, we don't tend to use it as much because of cost reasons, because of involving an anesthesiologist. But we have quite a few chronic pain patients who are seen within our system. If they're on high-dose opiates or high-dose benzodiazepines, so chronic pain meds like Norco or MS-Contin, or they're on Valium or Ativan or Xanax, those patients a lot of times are much more difficult to sedate. So because of that, a lot of times propofol will work much better. And so for those patients, we'll actually schedule them with an anesthesiologist so that we can have them receive propofol and have a much better response to that. And other times when I'll use that is if we have patients who I was not able to adequately sedate despite large doses of the Versed and fentanyl. Those people with their follow-up or subsequent colonoscopies will plan to do those with propofol. Another group where I think it's helpful to use propofol as well is for people who have a lot of medical comorbidities. So if you have a patient with coronary artery disease, congestive heart failure, type 1 diabetes, or they're diabetic and on insulin, or COPD, those patients a lot of times I think benefit from propofol because you have that extra provider there who's watching them more carefully and can make sure that they're not being over sedated or they're having blood pressure or other respiratory difficulties. So I do think that is advantageous. So we use an ASA grade, which is actually an anesthesia grade based on how severe their medical illnesses are, and that can help to determine if they would benefit from that. Like I said, cost is a very big issue with this. On the endoscopist side, it's really nice because you have that extra provider. Things go much more quickly. You don't have to worry about following the patient as far as how they're responding to the sedation. That's all handled by another provider. And then that extra person in the room helps significantly for room turnover. So in a lot of endoscopy centers, this has become sort of the standard of care just because it is so much faster. So if you're looking to get these procedures done much more quickly, propofol certainly does that. As far as for the population that we take care of and that CCSP has been more dedicated to, this is a much bigger difficulty. Medicaid and most private insurances, Medicare will cover for propofol. However, what the patient has to pay for it may be significant. Now with Medicaid, that's not such a big issue, but for private insurance, it can be a very big deal. A lot of times these things are billed at over $1,500 for just the anesthesia side of it. So even a covered procedure, when my wife had this procedure done, the amount that it actually cost for just the propofol portion was over $800 was the amount that we had to pay, even though it was supposedly covered by insurance. So this can be a very big issue for patients. And in the overall, it's a huge issue. If you look at the fact that the cost that's being billed for the anesthesia is actually, in a lot of cases, double of the provider or endoscopist fee for just the procedure itself. So it is a huge increase in cost for some benefits, but maybe not benefits that are up to the amount of increase in cost. So that covers basically the two most common ways that sedation is done. And then the third is what I think I was asked to talk about mainly for this, which is sedate, or as an unsedated, or what we call sober colonoscopies. And this is something that a lot of times a lot of providers haven't done. So this may be something that may not be offered or available at your site. I think it just kind of depends. I wasn't trained in doing procedures this way other than doing the flexible sigmoidoscopies. I'd had the experience in rural practice where we didn't have a flexible sigmoidoscope, and this was before Medicare was covering for screening colonoscopies. And what we would do is we would do a regular bowel prep. We would use a colonoscope, And we would start off with the intention that we're just doing a flexible sigmoidoscopy. But if the patient tolerated the procedure well, sometimes I'd find that I would actually get to the cecum, the end of the colon, and they would only need the procedure again in 10 years. So I'd had a few cases where just unintentionally, I realized that I was doing unsedated colonoscopies. Then, working here at Salud, we have, as most community health centers would have, a population where transportation, social issues, community supports are not necessarily the same as they are for a lot of other people. Because of that, I started to see patients who the ride home was one of the big barriers to them actually receiving colonoscopies. So what I did, and this came out actually from some patients who were coming down from Estes Park originally, where they had arrived for their procedure, they'd done their prep, they had a ride planned, but then their ride bailed on them at the last minute. So since they'd done their prep, they just arrived at the hospital and wondered if there was anything that we could do. So what I decided to do was try and come up with a little bit of a pre-procedure cocktail that I could do that they would be able to drive with, but might make the procedure more comfortable. So what I do, first of all, is setting expectations. So these are obviously motivated patients, and they want to get the procedure done, and they need to know that this is not going to be a painless procedure. This is not going to be something where they're going to sleep through the procedure. But I think they need to know too that it's not going to be a torture session, that this is something that can be done relatively comfortably, but that it's very different than having the procedure done with sedation, whether it were Versed, fentanyl, propofol, or anything else. Then what I tend to use are two medicines. So I'll use Levsin, which is hyoscyamin, which is an antispasmodic. In the hospital, we have it where it can be done sublingually underneath the tongue. And what this does is helps to prevent spasm in the colon when air is used for the colonoscopy. The thing to know about Levsin or hyoscyamin and other things in its class is that these are anticholinergics. So anticholinergics are medicines that are not great oftentimes for use in the elderly. So if you have a very elderly or sickly patient, this may not be the best medicine to give to them. But I find that it does seem to help as far as for air. One of the other things that we've done that I think has made a significant improvement in this is instead of using air for insufflating the colon, for opening up the colon during the procedure, we actually use carbon dioxide. Carbon dioxide is absorbed or reabsorbed through the wall of the colon 1,000 times faster than air. So if you're at a center that's still using air, you're probably familiar with the fact that when the patient is in recovery, they're oftentimes somewhat uncomfortable, feel like there's gas or that they have to pass, and oftentimes don't feel better until they pass that gas. And it used to be one of the parts of when you could discharge a patient was we didn't let them go until they had passed gas. With carbon dioxide, that just doesn't happen. It not only is, I think, much more comfortable during the procedure, and this includes for the both sedated and unsedated. I think we use less medicines with that. But in recovery, it's a huge difference. So patients are not uncomfortable with this. It goes away much faster. The next medicine that I use is Toradol, which is ketorolac, which you may have in your clinics. So this is an NSAID that can be given parenterally. So it can be given through an IV, can be given IM. And I know in clinic, we use it not uncommonly for things like migraine headaches, that kind of thing, when we don't want to use opiate or don't have opiate pain medicines. So the nice thing is it does not sedate. It's just an NSAID. So it's like, I always call it like turbocharged ibuprofen or Advil. It works really well for kidney stones, and I also think it works very well for the discomfort of a colonoscopy. So the thing to know about this is that so there can be some risks of GI bleeds, but this is a one-time dose, so that risk is probably fairly negligible unless you have somebody who's on other NSAIDs. And then I think the more important thing is as far as kidney function. So We deal with a lot of elderly patients. We deal with a lot of folks with high blood pressure, diabetes. Routinely, I tend to be able to see what kind of kidney function a patient has. If they have significantly compromised kidney function, then I tend not to use this medicine because I don't think that that risk is worth the potential benefit. So that's the one thing to know about those. So basically, Toradol and Levsin before the procedure, I think can be helpful in making it better tolerated. The other thing that I do is doing the procedure oftentimes with water insufflation on the way in and limited air insufflation. So warm water instead of air can help as far as to open up the colon, tends to prevent spasm, makes it a little easier to go around turns because if you can imagine the weight of the water, and we can actually have a pedal where we can push on this pedal and then water sprays from the colonoscope. And what that does is that actually puts some weight on certain parts of the colon so that then it tends to straighten out tight curves, things like that, so it can make it a little easier to pass the scope if a person has particularly tortuous or twisty, turny type colon. So water insufflation tends to help with that as well. That water is then suctioned out as we come out of the colon because you can't see well through the water. You can see, but it's not the same exam as we normally do. So as far as then once the end of the colon is reached and actually withdrawing the scope, there's really no differences in the technique that we would use for an unsedated colonoscopy. So there's certain people who I think are good candidates for using water or using unsedated colonoscopy. So it can help a lot for patients where they're having transportation difficulties. But if you have patients who are having problems with abdominal pain or other abdominal symptoms before the procedure, such as irritable bowel type symptoms, change in bowel habit where they're having problems with severe constipation or diarrhea, those patients maybe not do as well. One of the other groups that traditionally I was always told, and it is, I think, more difficult sometimes as far as more twists and turns for female patients because of the uterus being there in the pelvis. And even if a patient has had a hysterectomy, sometimes there are some more difficult turns to navigate. However, I've had the same success rate with doing unsedated colonoscopies on both men and women. So I've had 100% reach the cecum rate in doing that over the last 20 years. So it's something where it is definitely possible to do, but I think it's important with a female patient just to let them know that there's going to be more twists and turns and potentially there could be more discomfort. I do think that the discomfort varies a lot person to person. So there are some people who are very sensitive to visceral stimulation. So, we see certain people too, you'll do a rectal exam before starting and they basically jump off the table. That patient may not be a very good candidate for this. Other people, it doesn't seem to bother very much at all. And a lot of those things I think are perhaps they're genetic or other things, but I think it's very idiosyncratic. So one patient will have one reaction and another, and you can't oftentimes predict that. But as far as female patients go, I've had, like I said, very good success with that. I've performed the procedure on multiple of our female staff at the hospital who work in endoscopy, and they've done great with that as well. One of the issues may be, like I said, that you may not have providers who've done this. And I think, I don't know if this was Elsa or Andy that heard about this, but when I had my colonoscopy done, I decided I wanted to do it without sedation for the reason of wanting to kind of know, was this actually, what was I having my patients do? I was recommending these things, but I didn't know exactly what it would be like myself. So when I had my colonoscopy done, I did the same thing, had the Toradol, the Levsin, and the provider I had do mine. He's extremely experienced. He's done over 30,000 colonoscopies, so he's done just a huge amount. He had never done a procedure without sedation. And he did a great job. It wasn't a problem. I think it takes a little bit more time and a little more patience because you have an awake patient who may be talking to you and is going to have some discomfort with different things. I don't think you can go quite as quickly as you could certainly with propofol. But I do think that it's obviously within the skill set of probably all of us who do colonoscopies to do them that way. People's willingness to this may vary. So I hope that helps as far as those particular issues. Are there any questions about these topics on unsedated colonoscopies, or should I go on to other topics?
We haven't seen any questions in the chat. I'd like to invite anyone to put any of their thoughts in the chat. Also, if you'd like to come off mute, you're more than welcome to do that. As a reminder, you can take yourself off mute on the lower toolbar on the left of the Zoom screen. And if you are on the phone, you can press *6 to take yourself off mute. I'll stop talking for a second to see if anyone wants to do that. And then I have one question I would like to ask, but I'll like to give everyone else the opportunity first.
Well, I see somebody who had a question. Do you give the patient a choice whether sedated or not? So what we tend to do is just assume that they would want a sedated procedure. And most people, that's what they want. And then if they have any questions or concerns about that, then I will offer that, yeah, we do these this way as well. And oftentimes our group here, as far as our team, will offer those things if a patient is asking about it, and they'll ask either Lupe or Carmen or Sue about that. And then they know that I do those procedures that way. And so that tends to be how I find out that they're interested in doing it. And then the question I see from that too is it easier on the body if you're not sedated? I don't know. I mean, I think it depends on people's response to sedation. There are a lot of people who have very, very positive experiences with propofol and with Versed and fentanyl. So propofol, people tend to have these very happy dreams, and so they like that. And I've had multiple patients, especially sometimes patients who have a lot of anxiety or other things, who feel really good with conscious sedation. So as we start to titrate those medicines, they'll say things like, now I'm in my happy place. Can I have some of this to take home? Things like that. And those people also tend to wake up very well from this. They feel like they had a great nap. They feel really good afterwards. Same thing with propofol. I think going through, and I can only speak to going through an unsedated colonoscopy, I don't know if I felt, it was one of those things where I didn't feel like eating a ton afterwards. Feels like you've been through something as far as, and maybe it's just the prep too. But I can say that the first cup of coffee tasted fantastic.
Thank you. One question I had that's come up in some conversations here at the university, or just some questions. Is there any concerns about not finding polyps as easily if the patient is unsedated and moving around? Is there any reason why the not having a sedated colonoscopy would result in any different outcomes than a patient that was sedated if the prep was the same?
I don't think so. My experience has been that, and how I think most people do colonoscopies, is that getting to the end of the colon, getting to the cecum, we're not spending a lot of time looking for polyps. We basically just want to get there, and that we spend most of our time looking for polyps when we're withdrawing the scope. And most of the discomfort for most people seems to be on that first part of when we're getting to the cecum. The reasons for that, and some of you may already know this, is that as far as the type of pain receptors that are there in the colon, is that you can take out a polyp and people don't feel anything. So, you think using something sharp or even electrical, like we'll use electrical cautery to do hot snare removals of polyps, that would be painful. It actually is not. The type of pain that gets transmitted, one, happens when we insufflate the colon. So there are these stretch receptors, and you can imagine that those are also stimulated when we're ready to have a bowel movement, or if people are constipated, it's a similar kind of sensation. So same thing if you have diarrhea. The other thing is that there are pain receptors that are on the mesentery, which is kind of like the suspensory ligament for the colon. And so as that gets pushed or pulled as we go around turns in the colon, that will also cause pain. And as we're withdrawing the scope, you're not going to have nearly as much of that. So a lot of times that discomfort is just not there during withdrawal. And then that's usually when we're looking for polyps. So in my experience, I don't think that there's really any significant difference as far as, for example, adenoma detection rate. It might be more difficult if you had a very, very prolonged colonoscopy, and those happen sometimes unpredictably. So you'll have a patient who comes in for a screening exam and they're full of polyps, and you're taking out large polyps. If that became an issue, then I think it might be something to reschedule and do it with, with some other form of sedation. But I think in general, with the duration of the procedure and the fact that most of those things are done during the more comfortable phase of the procedure, it's not so much of an issue.
Thank you.
Oh, one thing I was going to say too about propofol that I thought was really interesting, and I was trying to figure out what was at other facilities, what they do as far as how long they keep patients after propofol. And it looks like everybody does basically the same thing with the amount of time for when we do conscious sedation, which for almost all folks, they'll tell people you shouldn't drive for 12 or to 24 hours. But when I was looking at some stuff on that, I found that there were some really interesting studies that were done in Japan, primarily. I think 3 or 4 were in Japan. But they actually did driving simulation after colonoscopies done with propofol. And what they found is that 1 hour after propofol, that people could drive fine, that they did great. And in fact, what they said at this endoscopy center where they were doing the test or doing the study was that that's what they changed to, and they routinely let patients drive from their colonoscopies done with propofol after 1 hour, which would be amazing. I mean, that would actually significantly decrease your cost if patients didn't have to take off work for an entire day, and they could do the procedure and then drive themselves home and then potentially go back to work. That's extremely interesting, but I don't think that's happening at all in practice. Are there any other questions?
I don't see any more in the chat at this time.
I'm looking for stuff that's on the list of what you were interested in. One thing, and I think I touched on it briefly, is the setting expectations for patients. And I think this is something in patient navigation, and it's a really important part in what we do in medicine in general. But I think for this procedure, it's super important. And depending on how closely you're working with the endoscopist, knowing what people do as far as what their practices are like, I think that setting of expectations is really important. So, when I do have patients say, well, I don't want to feel anything, I don't want to remember anything. And if I tell them what conscious sedation is like, and that still is not appealing, then I'll go right to setting them up with propofol if that's possible. Because if their expectation is that, they're not going to remember a thing, they're not going to feel anything, we may not be able to accomplish that goal if that's important to them with just conscious sedation, and they may do better with propofol. And something that's interesting with that too is that that in my experience, a lot of times are the chronic pain patients who tend to be the ones that are much harder to sedate anyway. So I think that that's an important thing. And then if you are in a situation where you can do unsedated colonoscopies, I think setting those expectations is important too, so that people know that yes, there's going to be some discomfort from it, what that might be like. And one of the things that I think is important with that setting of expectations is that I think that has a huge influence on what the patient's experience is. So in a lot of the world, colonoscopies are done without sedation. So I've taken care of a lot of patients who are from Scandinavia. They don't use sedation there. My family's from Holland, from the Netherlands. They don't use sedation there for their colonoscopies. And when I talk to patients who had their procedures done there, they're totally comfortable with that. They know what it's going to be like, and their expectations are in line with what the experience will be. Of interest is that there are certain places in the world where they do these without sedation for both colonoscopies and upper endoscopies, EGDs. And I've seen quite a few patients from Eastern Europe and Russia who had these procedures done, especially EGDs, and had a very traumatic experience. Were being held down forcibly, had it sounded like just a brutal experience, and were really nervous about it the more I talked with them. And I did all those procedures with conscious sedation, and patients did perfectly well. But I think that just shows in a really dramatic way how important it is to give patients realistic expectations of what this procedure is going to be like, not only for the prep, but what the actual procedure is going to be like. And I think overall, if people understand that, they'll have a much better experience.
It looks like there's a question from Lucy, actually, that just to me. She was wondering, having had an unsedated colonoscopy, what can you tell us about how it actually felt? Pressure, pain, etc.
Okay. Yeah, no, and I think that's important. And that was kind of what I was looking to get out of doing the procedure. So I was actually surprised. It was not nearly as painful as I thought it might be. It was actually, so the getting to the cecum part wasn't too bad at all. You could feel some pushing, pulling, that kind of thing. It's a funny visceral sensation, so kind of deep in your stomach. It's definitely uncomfortable and a little unnerving. I remember when, so one of the things that happens commonly as we're getting to the cecum is that we'll form loops. And loops are just a natural thing that happen with the endoscope. And what we do to reduce those loops is that we'll pull back the scope. And when we pull back the scope, what that does in an ideal situation is it actually causes the colon to kind of accordion on the scope. So it makes it shorter, reduces that loop, and then we can go forward more easily. And I remember when my endoscopist was pulling back the scope, that was a very unusual feeling because it felt kind of like a den of snakes inside my stomach, everything moving around. But it wasn't exquisitely painful or anything like that. And then on the way out with looking for polyps, I definitely could tell when he would put in more air to be able to see better, or like I said, CO2. It would go away quickly, but it felt kind of like the cramping that you might have with diarrhea. It was not severe, and certainly didn't last for a long time. But I think, like I said, I think everybody's a little different as far as what their personal experience was. But certainly my experience was that this was significantly less painful than I thought it would be. It was uncomfortable at times, but brief. And I thought something that was definitely very doable. As far as the next time, I would do the same thing and know that I can drive myself home. I had an IV, and I had my wife on available if I needed it for a ride, for just that reason that I didn't know if it would be comfortable enough that I'd want to finish the whole procedure that way. And it actually ended up, like I said, being much easier than I thought it might be.
Thank you for sharing your experience.
No problem.
We'll give it just another minute to see if anyone is typing in.
Sure.
Not a
One
question,
of the,
but thank you.
I was just going to say one of the things too. I think uh, the ride home is just such a significant issue that anything that we can do to give some other options for it, it's just so problematic for quite a few patients. And when you look at one of the populations that we deal with a lot, which is Medicaid patients, it's just huge that you have so many patients who don't have rides. And we've had some success with some of our work or support workers through Medicaid with getting rides arranged, but it still is one of our biggest issues as far as barriers. We've, I think, eliminated a lot of other things as far as, we have discounted procedures, we have discounted prep medications, we have all these different things, but the one of the major barriers that really remains is that problem of the ride home. So I think the unsedated colonoscopy is a reasonable option, and it is definitely helpful. And it's how I think one of the most common reasons that I end up doing them now is the patient who can't arrange a ride home, does not have those social supports.
Thank you very much for your time. It doesn't look like anyone has any other questions at this time. We have recorded this webinar, so we will be sending out a link to the recording to everyone. So if there's a particular part of this talk that you'd like to go back and reference, or if you'd like to share it with anyone else, that option will be available.
And we welcome you. If you think of something after the fact, please let us know, and we will reach out to Dr. Elzinga and get those questions answered for you as well.
I am putting a link to the evaluation of today's webinar in the chat. Like always, if you could take a moment and give us some feedback, we'd really appreciate it. And we will be following up with that information with Dr. Elzinga as well. I'm also putting in the chat the link to the webinar that is happening on Monday. That is the webinar on cancer screening and homeless navigation that we're putting on in partnership with the PNTC and the Colorado Cancer Coalition. That one does require a registration, so this is the link to the registration. And if that's a topic of interest and you have the time, we'd invite you to join us on Monday.
All right, perfect. Well, thank you so much, Doctor, for lending your expertise. We really appreciate your support and just in general your support of this program and the work that we've been doing for years. You've really been a champion, and so we are just very grateful. And thank you so much for your time, and thank you everyone else for taking your time today to join us.
You're welcome. My pleasure.
Thanks, everyone. Have a great weekend.